reason why the table needs to be flush against the stage. Yeah.
You gonna sit down?
Yeah, but I was.
No, that was Patrick. My partner in crime at this stuff.
Then let's go with it. Okay. I don't want Radon. Radon, you're gonna be kind of lost back there, so we need to maybe.
Well, I'll move here.
Yeah.
Does everybody want to slide down?
Well, I'm gonna stand with the questions, so that'll work.
I mean, if you want me to answer questions, just tell me and then I'll just.
Yeah.
We
That's fine.
you guys could share a chair because he's going to be standing.
I'm gonna stand.
Yeah, it's just
And Sandy, you,
I'm gonna go
and then
back.
you're gonna go sit down, so
So
we'll be
we'll
fine.
just move a chair back.
Yeah, we'll be
yeah,
fine.
we'll just push it
Fine.
back.
Yeah, no problem.
But we want to make sure that no matter what we do, Gary's sneakers aren't done.
Gary, sneakers.
I know, I love your sneakers too. Are they Aldo? Is that Aldo?
No, it's actually Colhan.
Colhan, okay.
I like those.
Look out.
We can do a shameless plug for Copan. The official sponsor of Healing Communities.
Maybe that's a way to
Our first corporate sponsor. Okay.
We've had offers. We jest, but
Yeah, there's that heel, sneaker, shoe.
Look, we'll try and
I'm going to make a copy of one of my most recent contributions from the community about what we should do. I'm gonna make a copy and I'm gonna send it to you. But on Friday, or the last day I was at work before I left, I got a very lengthy letter from an inmate in one of our penitentiaries, who's also a paralegal, who's been in jail or in prison for opioid problems and has been working very hard reaching out to Mitch McConnell and all kinds of other people to try and change the law. I mean, it was very, very thoughtful. But when I picked it up and it was like Blackburn Correctional, I was like, oh God, don't tell me I want to go get in the fan club from the prison. It's like, this is not what I hope for.
Radon has gotten many of those over the years. Okay. Yeah. We get some amazing letters from people in correctional. The last one we got literally made us all stop and cry. It was this guy who's been in for many years. He's training to be a substance abuse counselor, and his request, which he said, I know it's probably highly impossible, but might you, Dr. Volkov, come to the graduation ceremony? And we all went, oh my God. So Nora did a video. First we called the warden.
Yeah.
And worked with them and whatnot. And she either did or is going to do a little graduation, a video for the graduation.
That's awesome.
I know, it was like,
That's amazing.
we just melted.
Yeah, that's so great.
But that doesn't mean we can.
Somebody wants to talk to you.
Please stop.
Turn it on.
Thanks for putting us on the agenda.
Oh, you're welcome. Thanks for agreeing to do it last minute. Thank you.
David's got my slides. So he's gonna take them. He's gonna leave it out. He'll take them.
All right. You guys ready?
Yeah.
Okay.
You guys ready?
You guys ready?
Okay. We're ready.
Good morning, everyone. I'd like to welcome you to the Public Policy Forum. My name is Sandy Comer. I'm the Public Policy Officer for CPDD. And we have a two-part session this morning. During the first part, we'll be discussing the Healing Communities grant that, grants actually, that were just awarded maybe 2 weeks ago. And then the second half of the forum will be an update from Friends of NIDA by Bill Dewey, and then also an update of what's going on Capitol Hill by Ed Long. For the first part of the forum, it's meant to be very interactive, so hopefully you guys will have lots of questions and we can have a lively discussion about this. So without further ado, I would like to introduce Jack Stein. He's the NIDA's Chief of Staff. Apologize for that. And he will introduce the Healing Communities effort.
Terrific. Thank you, Sandy. I believe we were advised to keep the microphone where it's at. Yes. Okay. Well, good morning, everyone. It is a pleasure to be here and to represent NIDA with respect to this very, very exciting initiative that we'd like to use the next hour to highlight, and we've designed it in a way that is actually going to be as interactive as possible. To back up, many of you probably were at the opening session where you had a chance to hear our director, Dr. Nora Volkov, talk about a number of activities that are happening at NIDA, in particular the HEAL initiative, H-E-A-L, Helping End Addiction Long Term. And this is a trans NIH initiative that was launched back in 2018. We were fortunate to be given access to additional resources, which of course has been a challenge in years past, but with a $500 million a year addition to the NIH budget, about half of that going to NIDA to conduct a number of different important studies, the HEAL initiative was launched. And today we'll be focusing on not one of, but perhaps the most significant and certainly innovative study to date that has occurred in implementation science. And so we're really very, very excited, and it is called the Healing Communities Study. Before we get into that, I'd like to just acknowledge our panel and how we'll be working. In a moment, I'll be turning things over to Dr. Radonna Chandler, who is the scientific director for the Healing Community Study, and she's also the director for the AIDS research program at NIDA. So her hands are very full, and she has very, very busy responsibilities, but we literally could not think of anyone better to take responsibility for helping build this very, very innovative, massive initiative. And then to my left, we have three of a number of our PIs that are working on this study. Dr. Jeffrey Samet, Dr. Sharon Walsh, and Dr. Gary Zarkin. Each will have a chance to introduce themselves and respond to a number of questions that both I'll be posing, as well as you'll have an opportunity. But before we begin, let me just ask a quick question. How many of you in the audience have had a chance to read the book called Dreamland? Okay. Great, quite a number of you. That's terrific. It came out a couple of years ago, and it really chronicles, in essence, what's happened in America over the last several decades, where in fact we're at where we're at with our opioid crisis. And Sam Quinones, the author of it, really focused and used the term Dreamland as a really interesting title. And Dreamland was an amusement area in Ohio, in a town in Ohio, which, like many towns throughout the country, had a place where people would convene and connect and socialize. And over the years, as often happens, these places get replaced, they deteriorate, and big box stores sometimes move in or parking lots. And that's exactly what happened in Dreamland all over the country. And that's why we're so excited about this study, which is really in an effort, and it's been the term has been designed very carefully, that our goal here is to really heal communities. And in a moment, you'll really get a better sense of how we have taken such a noble concept and a bold concept and translated into actual research study that is actually going to hopefully make an impact for many, many years to come. So with that, let me turn things over to Dr. Radonna Chandler, who will walk us through an overview of the Healing Community Study, and then following that, I'll be engaging our panelists in a few leading questions to get the ball rolling, and then we're going to open it up to you all. So keep in mind any questions that you may have about this study, and we'll try to accomplish as much as we can in this hour together. And then, of course, there's going to be lots of public transparency with respect to this study. We'll make sure that you know about that. So with that, we welcome you. Please get comfortable, and let me turn things over to Dr. Radonna Chandler.
Thank you, Jack. It's a pleasure to be here this morning, and it's a real privilege to be the scientific director for the Healing Community Study and to work with these fabulous scientists and as, if not more importantly, with their communities that volunteered to be a part of this journey with us. So I'm going to spend a little bit of time just giving you a high-level overview of the study, and I don't need to really go into the background. Everyone knows that opioid overdose fatalities continue to rise. But the Healing Community Study was envisioned and developed because we recognized that unlike other types of addiction, we have an entire toolbox of effective interventions, including 3 FDA-approved medications, as well as a medication to reverse overdoses that are available for opioid use disorder. We also have a number of effective behavioral interventions. But what's happened is that penetration into the places and spaces where individuals need those interventions the most has not occurred. So the Healing Community Study is about really a bold effort to try to address that, to work with communities to help them understand their unique needs, and then to rapidly develop a response strategy that would integrate evidence-based prevention and treatment interventions in an integrated system across multiple settings. So there are 4 goals for the Healing Community Study. One is to develop and test strategies that help communities to respond to their opioid crisis, with a significant focus on a primary outcome of reducing opioid-related overdose fatalities and improving other outcomes. We want to measure the impact of an integrated evidence-based prevention and treatment care cascade for opioid misuse, opioid use disorder, and fatalities. Across multiple settings, the grant requirement was that each applicant had to come in with, at a minimum, healthcare, behavioral health, and justice willing to work together across each of the communities. In addition to other organizations that have also come on board, like faith-based organizations or child welfare services. We want to determine the factors that contribute to successful implementation and sustainability of the community response strategy and the integrated continuum of care. And then really importantly, we need to look at health economics, the incremental cost and cost effectiveness of the integrated continuum of care and of the intervention with the communities. So sites had certain requirements when they were applying, which speaks to a part of the answer of how'd you get the communities that you have. It was mandated that they had to be highly affected, that all of the communities had to be defined within some type of a geographic boundary and had to be within a single state, and that they had to have higher than average rates of overdose mortality and opioid-related morbidity, and that at least 30% of the communities had to meet a definition of rural. They also had to leverage federal, state, local, foundation, and other resources and infrastructure to accomplish a couple of different things. One was to collect data, because in a lot of areas there are efforts to be able to improve data collection around overdoses as well as around other proxies related to treatment that are supported by entities like the CDC or also by local states and local county governments, and then also to be able to deliver prevention and treatment services. The Healing Community Study is not intended to be funding a lot of the treatment resources or prevention resources, because we want this to be sustainable. So they needed to demonstrate how they were going to leverage things like SAMHSA funding or other types of state funding or a CMS waiver program for providing treatment. It had to include healthcare, behavioral health, and justice. They had to include as key personnel a governmental official that had the ability to influence lots of different factors related to prevention and treatment across all of the communities. They had to apply a cluster rather than an individual trial design. We're not trying to prove that these interventions work. They are all evidence-based. That's all been proven already. We are trying to figure out how to implement them. And then initially we said they had to implement common data elements and approaches. However, now the steering committee decided at the initial kickoff meeting to move to a common protocol. So there is a single healing community study across 67 communities. Here's our outcomes. Our primary outcome is a very ambitious outcome, and it's one that creates anxiety, but also I think makes us all feel really proud, because we're not talking about a p-value. We're talking about reducing opioid-related overdose fatalities by 40% in 3 years. And then we have a number of secondary outcomes that map logically onto the primary outcome of reducing overdose fatalities. The healing community study is taking place in lots of different settings. There's some examples in front of you around healthcare settings, around justice settings, and around other community-type settings. And so I can talk briefly about some of the components of the intervention. The intervention is based on an adaptation of the Communities That Care model that was initially developed by David Hawkins and colleagues to look at how to get effective prevention programs into communities for substance abuse. And so we've added some different components to it, including a sustainability component. We're embracing system science throughout the process because we want these communities to be learning communities and to be leveraging data to improve their response strategy. We have an implementation science framework, and there's multiple iterative feedback loops, and it encompasses 6 steps. The first is sort of getting started, which is kind of figuring out who's in your community, who might be willing to participate. Getting organized involves things like setting up community coalitions and getting organizations aligned to be a part of the study, developing a community profile using epidemiological data, a landscape analysis, and other data so that you can have a strategic plan that's data informed, being able to create that action plan, implementing it, and then in an ongoing manner evaluating it and feeding that data, those metrics, back so that you can go back and continue to improve your plan. And then there's a sustainability component that we'll be looking at. There's a whole big, very eloquent implementation science piece to this study. I'm not going to spend a lot of time talking about this, but here's some of the types of questions that we'll be looking at and considering as a part of the implementation science. And some of the different measures that will be involved. And then just to give you a sense of, well, what might be in that continuum of care, we're looking at evidence-based interventions in prevention, in being able to seek and engage people who are not in treatment, and being able to treat them and retain them, and providing recovery support. And then there are some structural outcomes and structural components of the study for evidence-based practices. So things like being able to find people with opioid use disorder that have lost tolerance. That can include individuals that are returning to community from prison and jail, or someone that's been through a detox-only program, using medication for opioid use disorder and other behavioral interventions and different interventions to be able to retain them in treatment, and then things like recovery coaches or smart recovery to be able to help them in their recovery moving forward. That is not all-encompassing, it's just a teeny tiny little sample. So RTI International in North Carolina has the Data Coordinating Center grant, and they are responsible for data collection, analysis, and the health economics and modeling study and dissemination of findings. And then the University of Kentucky with Sharon Walsh, who is here with us today, has the Kentucky site. The orange indicates rural communities and the teal blue urban communities. And you can see the opioid overdose rate for the 16 communities in the study. That's not what you would see in CDC for the state of Kentucky necessarily overall. This is specific for our communities. Massachusetts, and Jeffrey Samet is here as one of our investigators, and you can see there the rates for the communities in Massachusetts. New York, where the PI is Nabila El-Bassal. And then finally, Ohio with Rebecca Jackson. And this steps back to data that is statewide data, not based on our communities in particular, but you can see how highly impacted the 4 states have been by the opioid crisis, including the fact that Ohio is still on a very steep upward trajectory, as is Kentucky. And here you see all drug overdose fatalities in those states. So I'm going to stop and then let Jack interface with some of the members of the panel so you can get a little bit more information about the economics as well as about what's happening within 2 of the states that are a part of this study. Thank you.
Great, Radonna, thank you. So, Radonna, as you're getting settled in, you've been involved in this study perhaps longer than anybody in its initial inception as design. So, and you've been with NIH, and particularly with NIDA, for quite a number of years. What's so unique about this study? Has something like this ever been tackled before at NIDA or at NIH? So I'm just kind of curious about your comments around the nature of this study and for us to be taking it on as an institution.
So is this on?
Yes.
This is the largest study of its kind that NIDA has ever funded. It's very ambitious. It's not, we've done implementation science in the past, but it's usually implementation science on one particular type of intervention, even if it's been across multiple communities. So we had a very large study in the state of Ohio, across many counties in the state of Ohio a few years ago, but it was only looking at buprenorphine, and that was the only intervention. So here you're looking at an entire continuum of care, and you're looking at a whole menu of evidence-based interventions across 67 different communities, which is very unique. You're also looking at trying to integrate and remove silos so that you've got the justice system working together with the healthcare system, working together with behavioral health and substance abuse treatment and mental health treatment, which has not been done before. The closest parallel that we have at the NIH is work that's been done at NIAID around HIV, particularly in developing countries where they've looked at being able to stand up the care cascade in parts of the world where incidence is very high for HIV. And so we actually consulted quite a bit with our colleagues from NIAID about their particular initiatives. We got some help from them in thinking about how to frame some of the parameters around. So for example, they said you need to really clearly define, like, what's the community need going to look like? So they gave us a lot of tips and advice around helping us just think about framing some of the big high-level components of the.
So simply put, no. Okay.
No.
Okay. It's really never been undertaken to such a degree, and I think that's just something to continually underline around the nature and the extent of this. So let's chat a little with our 3 panelists, and actually, if I could just ask Sharon, Jeff, and Gary to briefly introduce yourself and the role that you're playing, and I wonder if you could also comment, just in a brief moment or so, what do you think we're going to get out of this study? I mean, when it comes down to it, we've got a lot of complexity in terms of designing this study, but ultimately it's about making an impact. I'm just kind of curious about your gut reactions to how's it going to change the world? Yeah.
Good morning, everyone. My name is Sharon Walsh, and I'm from the University of Kentucky, and I am the director of the Center on Drug and Alcohol Research there, and I historically done laboratory-based studies around medications and clinical trials, and I'm not an implementation scientist. Fortunately, we have an outstanding implementation scientist at the University of Kentucky that's been incredibly helpful, Hannah Knudsen, in helping us pull all of this together, along with a really broad team, and I can't name everybody right now. So when we saw the FOA coming out and we were aware of the study, we felt that we didn't really have a choice but to try and apply for it because Kentucky is so significantly impacted, And we have a tremendous amount of expertise across faculty in different colleges, and we all work together in different ways, but we've never come together as a broad team. And so we had some kind of initial discussion meetings about, what we thought it would look like and whether or not we really were committed to doing it. And every single person was 100% on board because they just felt like it was such an important opportunity. So I think what I expect to get out of this, well, first of all, I'm going to come out there and I'm going to say I think we're going to achieve our primary outcome. We're going to reduce opioid overdose deaths, and I hope that it's going to be by more than 40%. And we know that other communities have actually been able to do this, maybe not able to sustain it. From my perspective, we have a huge gap between what we know works, what this body of people here in the audience knows works, and what happens in the community. And so we see a lot of treatment in the community that's not evidence-based, and we see a lot of stigma against those things that are evidence-based. So I think that we're going to really be able to reduce stigma through our interactions with the community and education. It's, the best way to change hearts and minds is to have the people who actually are living in the community change their heart and their mind, and then talk to their fellow citizens. And so I think stigma reduction is going to be a really big thing. I think we're going to show that when we really mobilize what we know works, that we can significantly impact and reverse the trends that we're seeing with overdose.
Terrific. Let's come back to some of those. Jeff, do you want to chime in as another research center?
Sure. Jeffrey Samet. I'm a general internist at Boston University and Boston Medical Center. My background has been with addiction work, basically trying to figure out how we better care for patients with addiction, and that's include HIV over time. We've developed quite a crew of addiction researchers at Boston Medical Center and more broadly in Massachusetts, and it's that resource that we tapped into to put our application together. And I'd say Massachusetts has done, particularly in Boston, has developed some innovations for getting office-based addiction treatment ongoing and brought to communities, in fact, and care within the hospital, addiction consult services up and running, so that we've been part of that kind of new wave of good treatment. But it has been striking. The numbers that Verdana showed in Massachusetts belie that advance, in that the communities, which is the focus of this whole effort, are still not there. And so to me, to answer your question, Jack, what I hope we'll get to is really to better understand, because this is an implementation science and we'll have the opportunity to look carefully, is how do you take what we know works and get it in place in communities. And it's 16 communities, so what does not get put into place, and then we'll even have time to look at what gets put into place with the efforts of the support from this grant, but what can be sustained without the efforts of the grant. Those are the big things. I'll put one more thing on the table, because we've been scratching our head a lot about it, so we're totally open to ideas, is that, we do realize that half the people that die have touched the medical system in somehow. In the emergency room, in an ambulance, in the hospital, primary care, but half never have. And so we're talking about reducing for people who haven't engaged. So it has to be more than the usual, how do we improve care, and how do we get people, I call it out of the woodwork, so that we can access them and begin to get them interested.
Terrific. Great, thank you both. Gary, I believe the mics are very hot, so you don't have to, you can just speak. I think it's going to pick you all up.
Okay.
And then we'll avoid the popping of the peas that I'm...
Great. Hi, good morning. My name's Gary Zarkin. I'm a health economist. I'm one of the multiple PIs from the Data Coordinating Center. Our contact PI is a man by the name of Rick Williams, data person, statistician, and another multiple PI is Kevin Conway. Many of you may know, who used to be at NIDA, who's joined RTI just recently. My background in the field has actually been fairly extensive. In the early 90s, when I got to RTI, I began working with my colleague, who many of you may know, especially on the health economics side, Michael French. We began costing methadone treatment programs. And at that time, the problem that we had in opioids was heroin addiction of a relatively small number of people. And in the early 90s, the federal government spent a fair amount of money looking at, tracking people through care, doing follow-up studies. And, since that time, we actually had a fairly large fall-off in the federal role, except until now, and this very exciting study. Again, as noted by Radano, we're focusing on the health economic components of it, the cost and cost effectiveness. We're going to be part of our role is also simulating cost and cost effectiveness results out into the future, and also looking at ways of predicting what will happen in other communities outside the healing community study, and using some of our cost and cost effectiveness insights into that. I will note in terms of getting what we're going to get out of it and looking forward, again, I'm very excited to be working with these PIs. RTI in general is very, very happy to be part of the group. We felt our background was really well situated and suited for this kind of role. And one of the other exciting points I want to make is that we're very happy with NIDA and NIH for bringing health economics into the study at the outset. Many of my health economics colleagues, I'm sure, understand the notion of, at the end of a study, an investigator might turn to an economist and say, hey, boy, we just thought of something. We should probably do a cost study. What can you do for us? And we often have to say, well, did you collect any data that will help us? And they go, well, no, not really. And so at the outset, we're fully engaged with the design and helping develop the instrumentation that we're going to need for costing. So we're very excited to be part of this.
Great. So I want to begin to shift in a moment to fielding some comments and questions from the audience. So please get ready to do so. Before we do that, two things I think worth exploring. The unit of study, and this is where I have learned very rapidly about the nature of this study. The unit of study is not the individual. The unit of study is the community. And I wonder if we can talk a little about how in the world do you design a study of such a magnitude where the unit is the community, when traditionally I think an NIH typical grant would be looking at the development of a medication or an intervention or a behavioral approach. This just seems to be such a huge challenge, and I know there's been lots of discussion. Would any of you, maybe Sharon, do you want to just jump in terms of what it took to get to the point that we're at around designing a study that involves really systems level change?
Right, so I think I should start by saying that when everyone who wrote an application back in December wrote their application, they wrote it for their communities, and they wrote it in the way that they thought was probably the best way forward. And then after the announcement of the awards, we have been working very hard to try and harmonize and align the 4 sites, which has its challenges, and we are really getting to know each other well. And we've made a lot of strides. We don't have everything resolved. But I want to put that up front because it's going to frame a little bit about how I answer the question, because I'm going to answer it about how we envisioned the community and how we thought we needed to interact with the community and get them on board. So in thinking about the primary outcome, which is to reduce opioid overdose deaths in a very short period of time, we knew that what we needed to focus on were people who already were impacted by opioid use, misuse, opioid use disorder. Those are the people that are at greatest risk. So there's a lot of other things that you could think about doing, like school prevention programs and things like that, but in the short term that we had, those probably were not going to really help contribute to achieving the primary outcome. So then the next part of it really goes to Jeffrey's question, is 50% of the people touch the system, the other 50% don't, maybe it's even more than that. How do we find those people? Because those are the ones that we want to serve and hopefully protect against overdose. And so that was part of our community selection process, actually, because we knew in the state of Kentucky, for example, that jails don't offer treatment, but jails see a lot of people for short term that are coming and going, and sometimes coming and going again, but they're not getting linked to care. There's a lot of people in parole and probation who probably could benefit from treatment, and what that treatment may be or may be allowed by their parole officer may not be evidence-based. And so that was also kind of a point where we could interact with our community and hopefully change perspective about what is effective. We have syringe service programs in Kentucky. I think that we're the only southern state to have a law to legalize syringe exchange programs. And when the law was passed in 2016, they left the decision about whether or not to have a syringe service program up to the local community. So even though it was legal, the local community would have to decide that they wanted to do that. And we felt that identifying communities that had embraced having a syringe service program was actually a sign of readiness for change. And we need people to change, so we use that as another marker. And that's obviously another place where people are being served, but they're not necessarily people in treatment. And then, of course, we had to rally the treatment providers and figure out what is it that they need. Why are physicians wavered to treat people and they can treat 100, but they're only treating 3? What is it that we're missing there? And then I think the final piece is, what were the recovery services? Because once someone gets into treatment and maybe they enter remission and they've stabilized, but they may still be at risk of relapse, what actual services are being made available? And because our focus is on evidence-based care, which means medications for opioid use disorder, what we know is that a lot of community mutual aid groups actually exclude people who are on medications. So how do we build resources within the community that can support those people who are receiving evidence-based care and on medications? So those were some of the touch points that we envisioned. It wasn't limited to that, because obviously emergency departments and other places, the courts, drug court, pre-trial court is an important place because those people may or may not get into the jail or go on to parole or probation. So we really thought a lot about who it is that we want to reach, and then how do we build the network to reach those people. And we borrowed from the Ryan White model for our application, and thinking about care navigation and having people from the Healing Communities Project in each of those places, those touch points in the communities, and then kind of building a network that would be sustainable.
I wonder if Jeff could expand on that. And Jeff, I wonder if you also perhaps touch on the important role that the voice of the patient plays and has been playing in even the development, let alone the implementation of this study.
Sure. Maybe 2 points. One, what you're speaking about, Jack, is the community-engaged research. So that was explicit in the call for applications, that this would be community-engaged research, so that really what the intervention is comprised of are options. And those are options that the community will get together with our community engagement team and our intervention experts and talk about what would be the best match for their community. And so that's the process, and there's more, but that's the process in which we'll embark upon working with communities to determine what works best for them, what's best. The other piece, you talk about what it is having the unit of analysis being communities. It's that what outcomes are possible. The outcomes are possible with patients, depending on what questions we ask. But that's different with communities. So now it becomes, and our data work group is saying, what are measures that's possible for us to obtain? We may be interested in something, but it may just not be obtainable. But things like, I jotted down a few, death, okay, that we should be able to get. Prescribing, the amount of opiate agonist treatment and injectable naltrexone being prescribed is something we ought to be able to get. Waivered MDs or NPs and PAs. So those are things we're trying to think about. How much opioid prescribing might be decreased or at levels that are inappropriate, or less likely to be appropriate initially anyway. So anyway, that's a whole nother level of thinking about community outcomes that we're grappling with.
Terrific. Well, I'm going to pose a question to Gary in a second, but as we do so, if you do have any questions or comments, please make your way up to the 2 microphones here, and be happy to field them and start engaging in some discussion. But Gary, can you talk a little? You actually mentioned very quickly in your introduction the use of simulation models to do some economic analyses. Could you speak a little about that as a technology tool and how it may be useful for a healing community study?
Sure, glad to, Jack. So an obvious question that comes up when you do a study like this, which is, again, we have to have a 40% reduction in opioid overdose deaths in 3 years. You'd like to know, projecting into the future, what might it look like in 5 years from now, 10 years from now? Can we take data from the Healing Community Study and maybe the literature and do projections of what the future might look like? Okay, can we project the cost and cost effectiveness in the future, and also what the opioid epidemic will look like as well? So simulation models are useful for that kind of what-if scenario. What does it look like into the future? The other thing that is very useful, especially when we think about the economic context, if we think about other communities that want to do analytics and figuring out how should they take the results of this study, they might say things like, well, I have a certain amount of budget. Given the results of the study, how might I take the interventions that are part of the Healing Community Study, and how might I allocate them in my community to get the biggest bang for the buck? So a simulation model will let you do these what-if scenarios. It's a very important part of the economic study. I have to say, even though RTI is sort of the central point of that, we have great modelers throughout the whole group. Every research site has their own group, and we're actually very excited about working across the research sites to develop a really great simulation process.
That's great. I mean, it's a terrific goal for us to have. Can you just imagine being able to use these type of tools in communities from here on in to really do some predictive modeling on how best to align services with need? So we already got like 7 or so people, so I'm going to encourage we do this as and actually Bertha Madras is the perfect person to start, because I know she was the leader of these rapid communication forums over the last number of years here, where we've literally been able to cover a lot of ground in very short. So I ask folks, quick identify who you are, what your question is, and we're going to take quick responses from our audience. But Bertha, welcome.
I wonder, Jack, if you can indulge me in 3 quick questions. So my first question...
The floor yields to Dr. Madras. Okay, good.
My first question relates to fentanyl. In 2005, 2006, we had a rash of 1,000 fentanyl overdose deaths, and when one super lab in Mexico, in Toluca, Mexico, was taken out, the deaths went back to baseline, almost none. And I'm wondering whether or not the HEAL consortia can capture the relationship between fentanyl supply and the initiative that you have, as well as the governor's initiative, and whether or not a 40% decline would be attributable not to a great infrastructure, but primarily because the main source of overdose deaths is declining. That's number one. Number two is each of the states that are involved in this have different governors, different state regulations and initiatives in dealing with the opioid crisis. And I'm wondering whether or not the investigators are fully integrated with the state initiatives and how they differ, and whether or not there'll be cross comparisons. My third question relates to the rapid rise in methamphetamine and cocaine, and whether or not there is going to be a consideration of this demographic, this population, and the risks associated with the next wave of deaths.
Terrific questions.
So I'll take the third one. The answer is yes. We're already very well aware. We're already preparing for it. We're already looking at collecting data. So yes, the rise of psychostimulants will be a part of the Healing Community Study.
Great.
So we'll continue to move backwards, and I'll take the second one. So yes, I mean, it was a requirement for each of the teams to have a government official, a key government official that was in a position of making policy. And it was also a requirement that you understand what the landscape is for other initiatives that are underway in your state, and that you leverage those. So as an example, I can speak to ours, which is all the states have gotten a lot of money from SAMHSA through the SOR and STR funds. And so we actually have the person who is the project leader for the state for all the SOR fund management, as she's half-time on our HEAL project, and she's half-time with the state. And we have cabinet-level partners, so we're hearing about what they're doing and what their challenges are, what new money is flowing. We're cataloging everything because we don't want to duplicate efforts. We also want to be aware of things that are rolling out in communities that may not have been randomized yet. So we're doing a lot of work in the background to try and monitor and also leverage the resources that are already available for communities.
Great. And Jeffrey,
And a brief response on the fentanyl. One, first off, I think your point is accurate, that there'll be many things impacting the opioid epidemic. It won't just be the Healing Community Study. We need to be cognizant of that. The carfentanil, if that comes out, we just have to be aware. So we will be monitoring toxicology when people die to know if fentanyl is increasing or some new agents coming on board.
terrific. Great. Thank you for those three. Is that Kurt?
Hi, yeah,
It is.
Kurt Rasmussen, NIDA. Wonderful, wonderful job, laudable goal, fantastic. It's really what we need. I'm delighted to see it, and we'll support in any way I can. I usually concentrate on developing new therapeutics, but I also realize that putting new therapeutics into a system that's not ready for it is not ideal. And so designing the system, what you're doing is fantastic. But you're working with groups that typically don't play well together. The legal system, for example. I love lawyers. Some of my best friends are lawyers, but they look at the world in a different way. What do you see as the biggest barrier to success, potentially around this, getting different groups to play together? When you're putting your head on the pillow at night, what makes you worry, like, we got to get this right or we're in trouble?
Well, look, your point is
Watch the peas.
one of those peas. Your point is fair enough, but I would say we've seen people play together that we thought may never play together before. So we're partnering with PARI, which is this police assisted, so at police stations and will welcome people to come in and get connected to treatment. It's taking that perspective that you actually can make partners that haven't been made before and use the ones that already exist and try to expand them that we're going with.
You couldn't get funded if you didn't have these partnerships, because a part of these folks being funded was not only that they submitted a written application, but they were subjected to a very thorough site visit. And during that site visit, they had to bring people from these different segments, and they had to actually answer questions about how they were going to work together and how they were going to collaborate. And some of the reviewers I see here in the room. And so they were making sure that when we showed up and when they were there as reviewers, that these people knew each other, that they weren't just meeting each other for the first time.
Another question?
Hey, I'm Gavin Bart at Hennepin Healthcare, University of Minnesota in Minneapolis. This is a really exciting project and very big, and we already mentioned there are so many secular trends going on already to address opioid use disorders in the communities. But there are other research efforts going on, whether it's the forthcoming J-Coin, whether it's the NIDA CTN, and other projects. As these other programs and projects begin to grow, plan, and recruit sites for their studies, should the message be stay away from these communities? Too much cross-contamination, bias? And how should other people respond when it comes to site recruitment?
Yeah, so I'm not going to speak on behalf of what NIDA's position is, but I can tell you that in planning our application, we already had a few large-scale projects underway in communities, and we explicitly avoided including them in our communities because of potential contamination for both. And then I had the most recent experience, I don't know if Ryan McCormick is in the room or not, but he submitted a grant and we worked on it together, and our emergency department was going to be one of the sites for an emergency department intervention. And he had to wrestle with NIDA staff around the fact that our county is actually one of the counties that would be included. And ultimately, we had to let go of that, and so he'll need to find another site because there was concern. And I mean, it's an interesting dilemma because we know that there's lots of different things happening that we can't control and we can monitor them, but NIH actually can control where they send their money, and I think that looks like the plan going forward.
Okay. Let's go.
Hi, I'm Debbie Carice. So incredible project, amazing efforts. I'm going to try to model Bertha, who is a hero of mine, and give you 3 quick questions if I could. One is that I'm wondering if there was any insight from the drug-free communities work that could be helpful or you know, could be some kind of a small guide. The other is I'm wondering if what you're looking at with regard to taking into consideration coroner coding and data issues. And then finally, just if somebody could clarify, what I'm hearing is half the people who overdose and die have never had an interaction with healthcare. Is that, I know you said ERs, EDs, does that include treatment?
I could jump in with your first one dealt with drug-free communities, which, for those of you not aware, is a very long-term program funded primarily through the Office of National Drug Control Policy. Previously, it's been administered by SAMHSA to really build coalitions and support throughout communities. And it's not a requirement in drug-free communities, but many of them have actually adopted the communities that care model that actually Radana had framed, which is actually the foundation for the planning implementation piece of this. So I'm actually very excited that we're actually borrowing from the prevention field, which sometimes feels as if it's getting short shrift for very good reasons, and it's really adapting a lot of those models to this community-wide level.
So I'm going to address the question about the coroner and death reporting, because that's really critical to the success of the study. And what we know is that the system is somewhat disorganized, right? And it depends on what state you're in and what your laws are and who is, you know, is the coroner actually, you know, an elected position and they don't have any medical background? Do they do any forensic testing? How many death certificates are coded incorrectly? There's stigma around coding death certificates for overdose. And so the 4 states that were chosen to participate each have a somewhat different system, and I can tell you that in Kentucky we've been working for the last 8 years really closely with our state medical examiner, and we have streamlined our process. Our turnaround on death certificates is fairly quick. All suspected overdose cases have a sample sent to a single forensic toxicology laboratory so that we can actually get the full kind of continuum, even looking at like different fentanyl analogs. What we've discovered for the primary outcome is that each state has a different capacity and a different system to do that, and so we're trying to come up with some common rules on how those would be identified using the best data that are available, and at the same time trying to improve our processes. And so we're trying to learn from one another about what the different states are doing, and then through our government partners that we already have on board, trying to either allocate resources to change things if they need toxicology testing, and to streamline the reporting effort. So there's a lot of work that's focused on this, which will leave the states in a better place because we actually will be able to have better, faster data that will allow people to respond.
And a brief response to the 50% not having touched the healthcare system included treatment sites. Yes.
Thank you.
Terrific, great, thanks. Your 3 questions. Okay.
Sam Friedman, NYU Department of Population Health. First of all, my congratulations and commiserations to all of you. It's a hell of a responsibility. I think we should also look back to the response to AIDS that NIDA very heroically and successfully did. Their Nader and Adam and then cooperative agreements things, and try to draw some of the quick lessons from it. One of the biggest successes of it was to train a generation of researchers on new questions, like how do you do outreach to get those 50%? Another was to bring in people from fields who were not involved in the drug field. And we are facing a situation, I think, where a lot of the projects do not, in fact, have community researchers and organizational researchers from the social sciences deeply involved in their decision making. If we can reach out and get them involved, we will try. You know, they have stigma towards drug research. That's one of the things that this opens up as a possibility to train a new generation of people who don't. We're also, in Nader Adam Co-op, developed a whole series of new questions. We're going to have to be open to that. For example, we talk about stigma. I'm often reviewing a lot of the stigma groups. Very little is known or being researched on the social creation of stigma in communities. There are groups who are doing it as organized projects, and we need to know how to work in communities to isolate them and to counter their influence. The Massachusetts researchers have brilliantly done some work where they've shown certain occupations and industries are tied into overdose deaths, which means we need to do some research into the social creation of pain, because that's the other aspect of people. And as we do these projects, I think we need to think about qualitative research, which I haven't heard mentioned, but I'm sure you've got. And one of the critical parts is going to be to see which things are working really well, which ones are doing really badly, and to get qualitative researchers in who start doing that. The other one is, Jack talked, I think, if I remember right, about Dreamland at the beginning, which I haven't read. But from what I know about it, the whole question of why did Dreamland happen is part of the long-term response to the opioid epidemic. And we're beginning to healing communities, it seems to me, to touch on a lot of the stuff we're comfortable with, the stuff we know about. There's a lot drug researchers don't know about that we need to know if we're going to try to take on that question.
Thank you. And actually, I want to, Radana, we are fortunate that Dr. Chandler oversees the AIDS research program at NIDA, has a long history of understanding of those dynamics, and I think it's just fortuitous that we're able to take advantage of her knowledge on how it will shape the future. Radana, you just want to make any comments just about the reference to what can we have learned from past epidemics such as AIDS?
Well, I think I already alluded to the fact that the closest model that we have for this study actually comes from work that's been done in the area of HIV and AIDS. And some of NIDA's early large-scale cooperative agreements that looked at the intersection of substance use and HIV were community-based types of research endeavors. And so we have tried to look back, as well as turning to colleagues at NIH that are continuing to do this type of work and learn from them. I will say that as with the HIV epidemic, when it was continuing to have such a large magnitude, and it still does right now in many communities, and in fact, there is an intersection between the opioid epidemic and HIV, and we are seeing hotspot outbreaks in Huntington, West Virginia, which was featured in the movie yesterday, is in the midst of a big outbreak right now of HIV that is all related to injection drug use, and that particular injection drug use network is in dire crisis right now. But one of the lessons learned in the area of HIV work, again, was you can build the best treatments in the world, but getting them to people and overcoming stigma is challenging. And they had to deal and are still dealing with both of those in the area of HIV. And that really the philosophy of many people in the HIV research area is that the community owns the problem. It's where the problem exists, it's where the problem will be solved. And that's part of why there was such a strong commitment in writing the FOA in ensuring that it wasn't just academics coming in and sort of landing in the middle of these communities and saying this is what you're going to do. And that it was even probably a little bit more than just community-based participatory research. I actually heard a scientist and an advocacy person in the area of HIV talk about community-generated research, and that's what you really want. And so we're really striving toward developing a different model where it's a little bit more even a community-based participatory, because that participatory sounds like we're coming to tell them what they need to do, as opposed to they're generating with us how to respond and what the research questions are going to be and kind of how to move forward.
Thank you. So we literally have about 3 minutes left, so if we can, give it a try. We have I see 3 people standing, so maybe we could do a minute a question and see if we can wrap up.
Great. Sarah Lani, University of Wales. I'm really pleased to hear Donna say that because it does lead into my question, which is, one of the really important lessons of the HIV epidemic was the really meaningful inclusion of people living with HIV in research design, implementation, dissemination, all levels. Can you tell us a bit about how not only people in recovery, but also people who are actively using drugs, opioids and other drugs, are included in the project?
And to complete your 1 minute, I would say that we each have community advisory boards, and I can speak for Massachusetts where we have a drug users union, and one active user is on that board, as well as a number of people in recovery with lived experiences. So that is a goal.
Great, thanks.
Toby Eisenstein from the Center for Substance Abuse Research at Temple. One of the biggest successes, I think, worldwide in combating the AIDS epidemic was needle exchange. And one of the initiatives that's happening in Philadelphia is they formed a nonprofit to make safe houses for injection. And I wondered if that's going to be part of what you are going to try to do. And the safe house has met an obstacle in that the federal prosecutor in Philadelphia has said he's going to prosecute the people that try to carry this out. I think it's under the Hatch Act, some obscure act. And what they're planning is that the people would bring their own drugs, the people that are injecting, and they would be able to have supervised injections so that if they OD, they can get naloxone treatment.
So,
and it seems if you want a 40% reduction in deaths, that would be a good strategy.
So I'll take that question on behalf of everyone. So there is limited evidence right now about safe injection sites, especially in this country. It's a very controversial issue. As of right now, we are not planning on including safe injection sites as a part of the Healing Community Study. We don't have any current information that safe injection sites will be in any of our communities. However, should that change, then we'll be revisiting that issue with the NIH and thinking about what and how we may or may not be able to incorporate that in the study. Syringe service programs are evidence-based, they are supported, and they are a very active part of the study in all 4 of the states.
Thank you. Let's take our last question, and then I know we're transitioning to another section of this, but I'll preface just saying this is the beginning of this conversation. There's a HEAL website on the NIH website as well as NIDA's. Literally just Google NIH HEAL and you'll come to this. And we're going to be trying to be as transparent as we can as this study unfolds so that we can all learn in real time as it evolves. Last question.
Thank you. I'm Judy Ashworth with Penny Associates. I'm also with Harm Reduction Therapeutics, and we're answering the FDA's call to get naloxone over the counter. We're trying to do it in a nonprofit model. So I'd like to just ask how your initiative is addressing Narcan access and also the stigma or the attitudes that Narcan is an enabler for abuse.
So we have 3 primary strategies that we plan to use, and one of those strategies is around overdose training, prevention and distribution of naloxone. And so I think all of the sites have distribution of naloxone on kind of a widespread basis as one of their interventions. I think that it would be really important if we could move it to over-the-counter status, and there are people working on that. I happened to be at a talk that the Surgeon General was at 2 weeks ago, and I asked that very question because he's a big proponent of naloxone, and I said, so what are you doing then? Because he's in a position of power, and he said, it's very complicated, but we're working with the FDA around this. And there's all kinds of different implications, both regulatory and then pricing as well. But I think that if we can continue to have that conversation and move that along, that would certainly go a long way to increasing access and decreasing price.
Well, thank you all. Gary and Radana needed to jump onto a Healing Communities conference call. So thank you for your time, CPD. We really appreciate your support, and we will continue to report out on the implementation of this important study. So thank you all. I'll turn it back to Sandy. Okay.
I'd really like to thank Jack Stein and Radana Chandler for, leading this presentation, and I'd encourage you to stay for Ed Long's presentation of our activities on Capitol Hill, as well as Bill Dewey's presentation on activities by Friends of NIDA. So without further ado, I will introduce Ed Long and Katie Van Landingham as well.
Thank you, everybody. I think it's important to know that everything that was discussed, and first off, Sandy, thank you for organizing the first part, and the folks from NIDA to coordinating. This couldn't be done without funding, and there's a lot of money we're talking about in terms of these sites, and we need to have multiple years of funding that yet have to be appropriated. First, I want to talk about CPDD and Friends of NIDA and Van Scoyoc Associates advocacy, because a lot of what we're doing is talking about funding for NIDA, and we are uniquely positioned because there are not a lot of other organizations out there, though they are in the drug abuse field, are not advocating for money. The first step, and I think we want to thank people who came to Washington, is we had our 3rd annual Advocacy Day. We had 19 in February of 26 of this year, 19 attendees from 11 states. We had 47 meetings. Number 1 item on the agenda was funding for NIH and NIDA. We joined with the biomedical research community, asked for a $2.5 billion increase for NIH, plus a proportionate increase for NIDA. And within that, continued funding. This would be the 3rd year of funding for the opioid, additional funding for opioids. The Healing Communities that were discussed is funded out of the HEAL money, and that is essentially been funded in 18 and 19, fiscal 18 and 19, $500 million a year, 250 for NIDA, 250 for NINS, National Institute of Neurological Disease and Stroke. We're advocating, we're in the midst right now asking for a 3rd year of funding for HEAL, and within that, funding for the Healing Communities. And another important issue is reducing barriers to research. This is not just for marijuana, but and it's also for synthetic fentanyl. They're all, which are about to be, marijuana has continued to be a Schedule 1. They're about to introduce legislation to make synthetic fentanyls and their analogs Schedule 1, and inherent in that comes out with restrictions on research. In addition, CPDD engages in other areas of advocacy regarding, there was a May 31st meeting of FDA on CBD, and FDA is trying to figure out how to regulate CBD in light of various issues, including the Farm Bill, a letter of support for youth tobacco, and another issue that's come up, a restriction or proposed restrictions on NIH-funded research on non-human primates. I'm not going to get into it now, but that is an issue that's come up in the fiscal 2020 appropriations bill. Show me the money. I know I've made this presentation numerous times before, and I'm always talking doom and gloom. However, I do have good news to report. There's been a significant change in overall funding for NIH. You know, we had a doubling from 98 to 2003, and then basically a leveling off, which resulted in basically about a 25% reduction in real buying power of NIH. Over the last 4 years, Congress has appropriated $9 billion total increase for National Institutes of Health. equivalents a percentage increase from 15 to 19 of 28.9%. That's a lot of money. We're still a little bit behind in terms of buying power going back to 2003 levels. And NIDA has actually done better than overall NIH. It's experienced a 38% increase in its base budget, largely due to the increased HEAL money, which has added $250 million a year for the last 2 fiscal years, 18 and 19. So that's good news to report, but that does not come on its own. One, we had to get the funding overall. Two, we had to make sure that the funding went to NIDA and not to Building 1, even though Building 1 and Dr. Collins has a lot of say over how these grants, on categories of grants, but it's very important that since NIDA does most of the research on opioids, that NIDA gets its fair share of that money. Now we're in fiscal 2020. We're in the process right now in terms of appropriations and funding. A little bit of background. I've gone over what's in the NIH appropriation. The President has requested a $5 billion cut. For NIDA, 1.419 was the 19 appropriation. President requested a $123 million cut. And we're dealing with Congress to try to not just restore money, but to add money to it. The House Appropriations Committee has actually reported out its 2020 bill. It's currently on the floor of the House. And within that bill, there's another $2 billion increase for NIH, bringing its budget up to 41. That $2 billion would be on top of the 9. That would be $11 billion over 5 years. And NIDA has a $69 million increase over 19, not over the President. It's 193 over the President's request. And that the House includes another $250 million for the HEAL funding, which is very important. This is where my doom comes in. The Senate has not acted. Why is that? Because there needs to be a budget deal to raise the spending caps for discretionary spending. There was a budget deal that covered 18 and 19 that increased it over the Budget Control Act of 2011. Without an overall budget deal, non-defense discretionary spending will be cut 11% from 19 levels. Defense will be cut 13%. And I might add that within that deal is going to be a debt limit extension. And without a debt limit extension, we'll default on our loans. And it won't really matter because I'll have to be working till I'm 95 years old because the stock market will go kaput. And I say because that's non-trivial because Mick Mulvaney is currently White House Chief of Staff. He's a Tea Party guy. He's counseling the President on this issue. And not to get too political, but it's very hard to figure out where the President is on certain things depending on time of the day. So there's a lot of uncertainty about whether there's going to be a budget deal. And the Senate so far has not acted on its 20 appropriations bills. So that is an issue that's pending. This is a chart that talks about appropriations, shows appropriations, shows you that the bars are NIH funding, and then the graph is the NIDA funding. NIDA's increases pretty much track NIH, actually more so. Success rates, I always like to throw this in. Success rates are somewhere, even despite the increases, still around 20%. This is not percentile scoring. This is for every approved grant, for 100 approved grants, how many funding-worthy grants, how many actually get funded? So out of 100, 20 get funded. That's 20%. We're still down from where it was at the height of the doubling, where NIH success rate was about 33%. I don't need to tell you that some institutes are funding in the percentiles, like NCI, around 9%. So it's still tough to get a grant in there, even though there's a lot of money. And all this HEAL money is not basic research, it's all on clinical and translational research. And these numbers for NIDA do not include HEAL funding. These are from the $1 billion or $1.1 billion of NIDA's portfolio. Now a little bit briefly, because on the HEAL initiative, it's not just healing communities. There's $250 million a year, 18 for NIDA, 250, 19, and we're searching for another 250 and 20. It's divided up into 3 other categories in addition to healing community studies. 70 million approximately for med development, expansion of the clinical trials network, significant expansion both in terms of the current nodes and also adding new nodes, and $30 million for the Justice and Community Opioid Intervention Network, that's JCOIN. Our goal in terms of what we can do, which NIDA can't do, is to extend the 18 and 19 funding for HEAL into fiscal 20 and 21, and ultimately to make that part of NIDA's base. It's very important because the healing communities money, there's 2 years of funding, 18 and 19, but the 21 and 22 is subject to appropriations. And also my understanding is they'd like to make it a longer study, not just 4 years, but 5, but that requires funding. So our goal is to continue that funding and ultimately to make the healing communities, the HEAL money part of NIDA's base, to make basically what was a $1 billion institute into a $1.5 billion institute, and to make that part forever and ever. So that's a pretty hefty goal, but to give you a sense of perspective, all this talk about Cancer Moonshot, the total amount of funding was $1.7 billion for then Vice President Biden's Cancer Moonshot. Our goal in the next over 4 years is to make $1 billion for opioid research at NIDA and make it permanent. So it's a pretty big undertaking, and I think so far we've been successful. A little bit about opioids, and in terms of what the situation is, the complexion has changed. These are overall numbers. Drug overdoses, as you all know better than anybody, from 16 to 17 continue and have actually gone up. This is compared to motor vehicle accidents. There's also another alarming trend that life expectancy is going down. It has gone down from 16 to 17. That's a small spike down, but still it's a trend. Other opioid facts, I have the Kentucky that you're seeing, particularly for the most hard-impacted states, the deaths have gone up from 16 to 17. And the other thing is, and this is the statistic that's the chart that's most interesting, is that this is no longer a prescription opioid problem. It's no longer a heroin problem. It's a synthetic opioid problem in terms of the spike in deaths. And that will be not just for opioids, it will be most likely for cocaine, which will be spiked with synthetic fentanyl, and it will probably be for methamphetamine. So this is an issue that's not going to go away. The complexion has just changed. These are the numbers. This is a good segue to, in response to the synthetic opioid crisis or synthetic fentanyl crisis, Congress and DEA, Drug Enforcement Agency, are trying to act very forcefully. The way they're acting is to make synthetic fentanyls permanently Schedule 1. Currently, they're subject to temporary emergency scheduling. That started in February 2018. That expires in February 2020. They want to make synthetic fentanyl and their analogs, isomers, or any component a Schedule 1 compound. The most important thing about that is anyone who's doing research right now, who's a Schedule 2 researcher, who's trying to develop a better understanding of synthetic fentanyls to develop antidotes, those antidotes are also going to be Schedule 1. The legislation that's currently being considered is called SOFA, which I can't remember the acronym, but it's been introduced by Senator Ron Johnson of Wisconsin, does the permanent scheduling, but has no exemption or streamlining for researchers. So there'll be and right now, as you know, if you're you're suffering from cancer, fentanyl, because it's medically useful, is Schedule 2. Synthetic fentanyls will be now Schedule 1 with restrictions on research. So one of the major areas that we're trying to work on right now, not tackle the issue of whether or not to schedule, but to focus on the need to research. Sandy has been interviewed by National Journal. We have been talking to Senate Judiciary Committee staff. There will be, and to try to assist the Senate Judiciary Committee, which is the Committee of Jurisdiction with control over scheduling in the Drug Enforcement Agency, to consider and to carve out a streamlining process for research on these Schedule I compounds. Otherwise, a lot of research will not occur, or they'll be delayed significantly. The other area that we're still in the conundrum that marijuana, despite some 33 states dealing with recreational marijuana or medical marijuana, it's still a Schedule I drug by DEA, and there's still Schedule I restrictions. So even though there's this whole wave of legislation occurring on a state level, DEA, because it still imposes Schedule I restrictions on marijuana, is restricting research on marijuana. So we don't understand, our researchers are not able to understand both potential benefits, but also potential harms of marijuana. So all this policy making is occurring in a vacuum. And I do want to add, and I mentioned this yesterday, the marijuana issue is not a bunch of Woodstock refugees living in Mendocino County. There's a lot of big money in the marijuana legalization effort. Altria, and also they've hired John Boehner, remember the Merlot-sipping former Speaker of the House, the former Senate Majority Leader Tom Daschle, former Congressman Joe Crowley, who was defeated by Octavio Cortez. I'm sure that Boehner's retainer is about $1 million a year. That's not being paid by a bunch of marijuana researchers or sellers or distributors. And also states are clamoring for all that revenue. All these policies are being done in the app. I mean, this is a huge public health experiment, unfortunately, without any basis in science. And for better or for worse, DEA is hampering that effort by imposing these restrictions on research. So there have been a number of bills to create a carve-out, a new sort of a Schedule 1A for marijuana that would facilitate more research. Last point, hemp is another, CBD is another big issue. The Farm Bill actually made hemp and its components that have less than 0.3% THC by dry weight no longer classified marijuana, therefore no longer regulated by the Controlled Substances Act. So that's brought into a whole question about CBD. The issue is now in the court of the Food and Drug Administration. There was a May 31st hearing on the issue. Elise Wirtz from CPDD and Ryan Vandry testified, along with many of others. They're trying to figure out how to deal with this very big issue. A lot of CBD is being sold on the internet. People are finding that there's no CBD in it. There's synthetics in it. There's THC in it. It's not effective. We don't know about drug interactions. So we're in a real Wild West situation with CBD. So I know that people think there's a lot of potential benefits, but there are a lot of potential consequences because we actually don't really know about adulteration and things like that, which is the province of FDA. Bill.
Okay, I'm just going to take a few minutes to tell you a little bit about Friends of NIDA. We started Friends of NIDA 15 years ago, and it's very important to point out that Charles O'Keefe and Jeff Mumford have taken a very leading role in this organization. What it really is a coalition of scientific and treatment groups, because when we'd go to Congress at CPDD, they'd say how many people you're representing. We could say about 1,000 people are members. Now we work with over 100 different organizations like CPDD. We don't replace what CPDD does, we try to add to it. And we are very specific to one point. 80% of all the research done in the world, not just in this country, excuse me, but in the world, comes from the federal government, from NIDA. Our goal is to increase the ability to do research for people who are funded by NIDA. That's our very specific goal. We're not into other issues, we're specifically that. We put briefings on Capitol Hill. Jeff Mumford takes the lead on that. We've had 25 of them. I think if the slide is up in the last one we had, and as you can see, the people who are involved with the leaders of CPDD, and CPDD has consistently taken a major work with Friends of NIDA. We have absolutely no employees. There are no employees with Friends of NIDA. We have very little budget. We do need some help from you in terms of funding, because to put on these briefings does cost us money, and we have to do that. But as I said, we don't pay any employees to do that. The last briefing, this one was on the problem that Ed just referred to, but we've covered the complete gamut over the years, and we take the most important issues to NIDA and then go down and argue for them and try to get increased funding and other things. The other thing that we do, and how do you advance this? Use that one? Yeah, the other things that we do is that we generate funds from you, from the scientific community, to award prizes for the high school students who are in the Intel Scientific Fair, the International Fair, and the outstanding students who win come to NIDA and present their research. And let me tell you, it's outstanding. It is absolutely unbelievable how much these kids, freshmen, sophomores in high school, can talk about drug abuse research. Our goal is to encourage them to stay in the field and join us and be scholars in this field. We need to continually refurbish the field. So Friends of NIDA supports this, and on August 12th of this year, these young people you're seeing in this picture will be at NIDA to present their research. One of the first winners came back about a year or two ago. He was a graduate student I think it was at Johns Hopkins, and he told the kids, it was really impressive, he said, I'm involved with recruiting graduate students, and each of you could get in our graduate program today. So it's working. We're keeping people in the field, and Friends of NIDA, as I said, works with over 100 organizations, and all we're trying to do is increase the opportunity for us to do the research that's been described.
I want to make a point. Bill mentioned that 80% of all drug abuse research is funded by NIDA, but also, as opposed to, and I've dealt with a number of other, Parkinson's as Michael J. Fox, juvenile diabetes at Mary Tyler Moore. We don't have like a high-level Hollywood star highlighting our issue. We also don't have private source funding like the American Cancer Society, and we don't have any other real advocates except you, and which is very important. So when we're talking about $1 billion or $1.5 billion, that's a lot of money. And unfortunately, we've been able to get some additional money because of the high focus on opioids and the number of deaths. And we want to, unfortunately, because we think it's going to continue because of synthetic fentanyl, we want to make sure that NIDA is the agency that can do the research. But we also, given a number of important policy decisions that are being made out there, in the absence of science, NIDA plays a very important role in developing the science that hopefully can influence policymakers as they review issues on synthetic fentanyl or marijuana or things like that, because NIDA-funded research is that science that hopefully will influence the policy decisions that are going to be made, because trust me, they will be made for better or for worse, but it's better that there's science that's injected in that conversation so that better outcomes come about. Any questions?
Yeah, so thank you, Ed and Bill. Question?
Hey, thanks for the presentation. I always like keeping up on this, and I hate to look a gift horse in the mouth when it comes to the HEAL funds. but I think as more and more communities are addressing opioid through various initiatives, whether it's SAMHSA, they're beginning to realize they don't have an opioid problem, they have a drug problem. And I do have concerns that all the earmarks that are very specific in the tracking of the HEAL dollars being tied to opioids, maybe I'm a naive optimist, but this wave will pass, and we're going to go back to the dry spells. And with the rise of methamphetamine and cocaine, what kind of efforts are being done to really argue for the increased funding of NIDA because of America's drug problems rather than as America's opioid?
Yeah, that's a really good question, and we're absolutely not ignoring the other drug-related problems that are in existence and are also increasing, including, the problems related to cannabis use disorder, with youth tobacco issues, with, synthetic drugs other than opioids. So we're really focusing on a broad range of activities. For example, just recently, someone from the FDA approached me because they're interested in putting together a one-day session to discuss the rise in stimulant use and stimulant overdose death, related deaths. And they asked if CPDD would be involved. So we're definitely planning to participate in that. So you're absolutely right, and we're not ignoring it. When we go on to Capitol Hill on Advocacy Day, we're covering all, different drug classes.
And I think I want to make your point that it is a Faustian bargain here, and I'm very much aware of it, but at the same time, the money does benefit the Institute. The crisis has brought the Institute into higher profile on the Hill and brought greater attention. And I do think the reality is the cocaine and meth issue is going to become more important because it's going to be a cocaine with fentanyl, a meth with fentanyl issue that's going to segue. So this is no longer going to be an opioid crisis, it's going to be a fentanyl crisis. And because I work in Hill and I deal with reality, I want to ride this train, I hate to say this, as long as possible so that there will be collateral benefits to the process. The reality is these healing grants are not basic research. They're clinical and translational, and the base budget of NIDA is still somewhere around 1.1. The success rate of NIDA is still around 20%. So we're very much aware, but at the same time, how can we maximize NIDA so on a longer term basis, people think about drug abuse and they think about NIDA as the premier agency to respond to it.
And I'd like to add, too, that one of the things about Friends of NIDA, as I mentioned, is specifically to support NIDA, because there are going to be these trends and these changes, and we're not always on top of them like the people at NIDA are. And on our board, like Dr. Madras, who's going to speak in just a minute, is that we have people who are former Congress people, we have people who were head of the drug control policy, all the previous directors of NIDA. These people know how to get in and get the job done. And it's very important they help us stay on that track because the drugs will change and the issues will change.
Time for one more question.
As a health educator, obviously concerned about the prevention dollars, the education and training dollars, that so much is being put into the clinical and the translational, and what about us that in the prevention field and in the education field? Are there dollars going to be set aside for prevention?
But it's not in the HEAL. It's not in the HEAL funding. The HEAL funding, as indicated, is for rapid results. 40% reduction over 3 years is the goal for the funding. It's our goal, ultimately that's our goal to sort of fill in the blanks on prevention and training. But right now, it's not on basic. So that plus up is a result of that. We also want to increase the base funding for NIDA as well, so that there's an opportunity to get into that other area.
And again, the point is to increase the money at NIDA for the experts to decide how to spend it.
There also needs to be more people involved in training, I know ASAM is involved in that. We've worked with them in the past in terms of through HRSA and other entities to do more training. Also, Bill has been very much interested about changing or adding to the curriculum of the curricula at medical schools about drug abuse. There's a whole greater need to deal with all aspects of this issue.
Thank you. Before I close the session, I just want to encourage everyone to attend Advocacy Day. I'm planning to organize another one for 2020. It'll be probably sometime in February, and it's a really important thing that we do as an organization. It increases visibility so that we can do the kinds of research that really need to be done. And so if anybody's interested, I'll send an email out to the listserv, but feel free to email me as well, and I'll add you to my growing list. So I just want to thank Ed and Bill for their presentations, and thank you all for attending.
And I also want to add, like Dr. Dewey doing this, Jeff Mumford for the sterling work he's done through APA in terms of organizing these briefings, which have been absolutely critical to getting greater visibility to NIDA and Nora and Sandy and Katie, who does basically, she makes sure I don't totally fall off the tracks, but also being helpful and being a co-partner in this effort, and also Sandy for single-handedly spearheading these advocacy days. And Charles for making sure there's money for Friends of NIDA and for his sage wisdom. And it's a team effort. Thank you, everybody.